We've talking about disc issues today. We've got a few different schools of thought which go on with disc issues. I'm Mackenzie trained, which has been around for a while, and it's a little bit about where discs, how they move, and a little bit more mechanical based. And it tries to probably simplify what we're doing with discs. There's a lot of people that don't believe about the Mackenzie theory. To be honest, from my point of view, it does work in my experience, and that's been a long, long time. For 20 years, it's or 20 plus years, it does seem to work. But you know, at the end of the day, everybody is an individual. Everybody has their own way of moving. Everybody has their own way of thinking, and no two discs are the same. So, from a sort of treatment or a management point of view, that's why you can never generalize. What we're doing is looking at what you do, how you move, what causes your pain to get worse, what causes your pain to get better, and then we manage it from there, given the best of our abilities and also given the best of what's worked for us in the past. And also, if you present what's worked with that type of presentation in the past, if it's not working and it's not responding the way we expect it to, that's when we need to change tack a little bit, which is probably the good thing. Having been in this business for a long time, I've got a lot of tacks and a lot of things that I can do to change. But yeah, from a disc point of view, we're just going to go through a little bit about what it means if you do have a disc prolapse, and I'm going to keep it really basic, really simple. Whether you follow the process or not, it doesn't really matter. What is that, you know, that having a disc can have an impact on how you move and what that impact can be. And the big thing you want to know is, are you making it worse and aggravating it, or is it getting better? Okay, so there is a video that we've done about, you know, anatomy or spinal anatomy. This is a very simplistic, real, like 2 minute, because we can talk for days on backs, but two bones of your vertebra. So these are obviously rigid. They need to be able to move, so they allow you to bend and stretch. And what allows that to happen is your disc. And your disc here is just a cushion. So think of it like like I said, I was taught as if it's a tube of toothpaste. It's squashy, it moves, it allows it to sort of move side to side. So when we lean forward, the bone doesn't crank on bone, it allows it to bend. When we move backwards, again, it allows that cushion. If we're jumping, we get a little bit of shock absorbency. The red bit that you can see here, that's where a little bit of disc has herniated out. Okay, now in terms of that disc herniation, if you think about the outer layer of your disc is quite fibrous, and it's on sort of 45-degree angles. So one line goes 45 that way, the next line goes 45 that way. So it's quite a fibrous thing. So think of it basically like a tire. That's the fibrous outer coating. The bit in the middle of the car tire, that's the bit that's got all the gel in it. So that bit that sort of sits in the middle. So it's like the polar bit is the fiber, the middle bit is what they call the nucleus, the nucleus of it, the pulposa, and it's got the gel in there. Okay, now as we move forward, we'll just get rid of that. So that's my disc. As we move forward, it can bend and it can stretch, and it allows us to bend side to side. So it's not just two rigid bones, it's got a little bit of cushioning as we move. Now what happens as we get older is that is a little bit squashed, okay, and the height changes a little bit, which means that as that height changes, the discs don't support the back as easily, and the bones can come into contact with each other. So if you think when you're sitting down or doing something that's quite loaded, the discs get compressed, and when they're nice and young, they allow that compression to happen. It's not such a big deal. We get up and we move around and everything redistributes. The key thing that you need to sort of be aware of is that as we lose disc height, we also lose a little bit of flexibility. So imagine that you're like a tube of toothpaste and you're able to move the toothpaste front and back, and it allows you to bend and stretch and do all those things. As we get older, it's a little bit like when you've left the cap off the toothpaste. It's a little bit sticky, it's a little bit harder to get out, doesn't move quite as freely, and you have to work a bit more to get it to go where you want to go. So a little bit like squeezing all the tube out. That's a fairly sort of decent analogy, and that's basically what happens. You know, you can move and move really, really easily, and as you get a bit older, you tend to get stuck, and then you sort of have to crank yourself back up, and then it's like I say, very simplistic view, but it's a nice way for the brain to accept what's going on. So you've got a harder fibrous outer casing, a bit of gel in the middle, a bit like the donut, and then a bit can herniate out. So if you can imagine that you've got your donut, you squash one end of it, and that gel herniates out. That's basically what happens with the disc. The actual outer surface of the donut has allowed some of that gel or the jam to squash out, which means that, however, in that scenario, the actual donut's still intact. Okay, the donut hasn't split and it hasn't cracked. It's just that there's a bit blown out. So that's this here. There's a little bit sticking out. It's been squashed and squeezed, but it's still contained within its outer layer, and that can then resolve and come back in. Okay, so what we're talking about when you've got an acute disc is that you've done something. Typically, if you've got your back here, typically you've bent and leaned forward that way, and what's happened is that section of your back, as you bend and lean forward, is herniated out. Okay, and that's what basically a disc herniation means. It means the actual nucleus of the disc has started to pass and stretch through the outer casing, and the outer casing is squashed and blown up. Now, because of that, that's a big bubble that shouldn't be there. So when you try and bend to that side, so if you've got a right-sided disc and you try and bend to that right side, you go, ouch, it hurts. So anything that compresses that, there's a great big bubble in the way, and your body goes, ouch. Okay, what it does like is going away from the disc. So you'll find that, people who say, well, my disc is on my right side, and they're leaning away to the left. And the reason you're doing that is to give that a bit more space. Okay, so if you think about that again, because this is my right side here, as I'm leaning this way, I'm pinching it, so I'm going to hurt. But if I lean away from it, I'm giving it some stretch, so it's pretty good. If I lean, spike out, pushing down then. If I lean forward, again, I'm giving it a bit of space, so it feels pretty good. But as I come backwards, again, I'm pinching it, so you might get that ouch. Okay. Thing is, walking is going to be quite good, because as I walk, I'm getting a little bit of natural extension, and it helps just push that disc in. Again, a little bit of an outdated way of looking at it, because there's a lot of different thinkings around there, but I still go on this premise that you are sort of moving that disc and you're using movement to help. You might find as well, if you do what they call Mackenzie extensions, which is when you lean backwards, or you see people who are doing that and say, yeah, that feels better. Sometimes what's happening is just helping guide that in, so they don't have that sort of lump there. Very simplistic, just as a caveat on that. But traditionally, discs will go out backwards, so there'll be a posterior bulge, or there might be a lateral bulge, which means they go out to the side, or a bit of both, which is posterior lateral. So instead, if I'm facing 12 o'clock, it might have herniated backwards at 6, or it might herniate backwards at 4 o'clock here. Very rare to herniate forwards, although it does happen. So typically somebody who has a back problem, when they're sat down, they're going to walk up their legs because they're trying to take some pressure off, and they're trying to get to the point where they're here. They might even like a little bit of extension when they're here, just to get that out the way. Okay, what they won't like is doing that, because that allows everything to get back into its pushed out position, and then it takes a little while to crank the legs. Or you might see them do this, they bend their knees and then straighten back out. So there's a few things that we're looking for. I don't know if you can see very well if I try to turn my chair down, but again, what they might do is they might be sat like this, so they try to get some space. So when they're sitting down, instead of sitting knees in front, they'll actually have the knee out to the side and the leg out to the side. So there tends to be sort of a few key things that we're traditionally just looking at that will give us a bit of an indication. Coughs and sneezes gives a bit of pressure and gives a little bounce to that disc. So in terms of managing it, what do we do? Well, acute discs are acute discs. you're going to have some swelling around there. If it, you sneeze or something happened, or you reach down and you think it's your disc that you've done, and you've gone and been investigated and it's an acute disc, you want to make sure that you're aware that that area has been damaged, that area is now inflamed, and take care of it and make sure that it's in the right place and that it's moving the right way. So doing this might make it feel good, but it's actually going to make it worse because you're not coming back to a normal functional movement. So in terms of how we manage it acutely, we're looking to take care of the pain, make sure you're doing things. If it's sore to sit, don't sit for too long. You're going to be better off walking, you're going to be better off lying on your back. If you're actually standing static, you'll find that that's loading. If you are sitting static, you'll probably find that that's loading. So the big thing is you limit what you do that causes pain. Unfortunately, some of the things that you do that help the pain might be things that we don't want you to do that might make the pain worse, but we're talking in the acute phase, okay? Once you've had a disc that's settled down, what you need to be aware of is where that little herniation came out, there's going to be a crack or a channel in that fissure, okay? So that little crack or channel in that fissure means that there's a little bit of weakness there, and that's what we need to be aware of, that there's a weakness in that little area there, and if you continually aggravate it or continually move and do stuff or continually do things, so typically gym-wise, if you're doing things like wood chops, where you're going on that diagonal, that's the type of thing as you reach down towards the ground that's potentially going to make it worse. Coming up in that way is probably the movement that we'd like to make it better. So if we're doing like an exercise program, or we're doing something where there's a lot of curls and a lot of things into flexion, we would generally then think about doing something into extension at the end to solve that issue, if that makes sense. So we're talking further down the track when you're doing rehab, or further down the track when you're thinking about designing an exercise routine. So if somebody has come in and they've generally had a posterior prolapse, or they've had a posterior prolapse that's been lateral, and they're 6 months on, a year on, they're relatively pain-free and they're comfortable, the biggest thing that we don't want to be doing is doing heaps and heaps of flexion all the time without counterbalancing that with some extension. You want normal movement. Just because you've had a back problem, you don't want to say, that's it, you stay rigid and you do this, and if you're bending, you bend from the hips. You do still want them to be able to flex. We do still want them to be able to extend. However, you want them to be able to do it where it's not causing them problems. So the graded return to exercise is what we're after. So in terms of managing discs very acutely, that's a physio job. That's a go and get treatment. Don't be sort of trying to do that on your own, because there's so many things that can happen, and you want to make sure that what you're doing, we want to clear organ-neural tests, you want to make sure that your straight leg raise is okay, you want to make sure that there's no involvement through the nerves, and you want to make sure that what you're doing is good, because if you go into back spasm will do that, and that causes more pain. You want to get the height restored, and you want to get the area around the disc and the joints that are involved stable, and then on top of that, then we layer in starting to move. Can you hold the back still? Move the legs. Can you hold the back and the pelvis still and move the trunk? Can you then start to incorporate a little bit of pelvic and lumbar spine movement? Can you do that and keep this still? Can you do that and move away? So it's not just, do this, go and do planks. You've got this, let's go and do some core work. It's a case of what is the area that's been damaged and work through that. So typically with your disc problems, posterior or lateral disc, you're going to avoid twisting and bending in the early stages. You're going to avoid twisting and bending with force, and it's even things like reaching behind you to get your handbag, reaching onto the floor to get stuff, putting your socks on in the morning, getting shoes on, reaching and pushing doors. So just basic general things, reaching up into the cupboard, that could cause problems because it's either straining a little bit of pressure on the disc, or it's causing a little bit of torsion and you don't like it because of how the back's moving. Okay, in terms of then how to translate that through to exercise, the things you want to watch out for is if you are doing something that flares it up and you think, what, that's not exercise sore pain, that's, pain I'm not happy with. Or, I do this and I start to get some sort of tingling feeling or numbness, or things that start to send sort of sensations down your leg. That's again when you need to be aware of it. If you haven't sort of been seen by somebody exercise, and I'm not knocking all the personal trainers and the fitness and what have you, but they just don't have the expertise. We have so many clients that we see that say, you've got X, Y, and Z, and we'll say, okay, that's great, we're working on this. However, you need to avoid this. And they're still doing work with their personal trainer or their gym, or they go to the gym and do their own thing. And we say, do not do this because we're working to get X, Y, and Z. And then they come back the next week and they say, my back's really sore, I don't know what I've done, what have you. And we'll say, okay, what did you do? What have you been doing? What have you been sort of working on? And they'll say blah, 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 blah. And then with my personal trainer, I did squats. And we'll say, well, we've told you not to do squats. Did we not have this conversation about not doing squats? But my personal trainer said I'm okay. He knows what to do with my back. He's known me for years. And great, but you've got to buy into the whole thing, because what we're looking at from a physio point of view is being really specific. And what we're looking at is, you have a disc problem that is here, or you have a facet problem, or you have this, and you need to do X, Y, and Z to work this certain area. This muscle's strong, this muscle's weak. Okay, we're trying to take down this muscle to allow this muscle to work. That's a little bit of a generalization as well. Now, when you go to somebody who is trying to train you to get stronger, they're trying to train everything. They're not trying to dampen that bit down to allow that bit to work. They want everything strong. And if you get everything strong, you get compression. And then you get, poor technique, because again, how we teach you to do a squat, if you're in pain or we're trying to be very specific, is going to be very different to how somebody else teaches you to do a squat. We spend all day looking at bodies, and what we're looking at is a little bit with x-ray eyes. How's that alignment going? How's this going? So if I'm doing a squat and I'm doing it in the gym, I'm going up and down, I might have some hold there, I might be doing some weight lifts in that position, and you can see my back there's in an arch. If I do this, you can see my ribs are sticking out here. If I'm doing it from a physio point of view, I'm actually going to want you to stabilize and come here and use your legs and your hamstrings more. And you can see from that point of view, I'm not arching. You can see from that view, I haven't got my ribs stuck out or tucked in. I'm actually very specific about how I want that squat done and what muscles I'm using. So trying to crank out 40 in 2 minutes flat because you're doing CrossFit, or you're trying to crank out 60 in X amount of time because you're trying to get stronger. We might just want you to do 5, and we want you to do 5 that you do really well, and 5 is fine as long as you do it really well. What we don't want is you try and do 50 with this poor technique as you think, because you want to do 50. So this is where some of the issues do tend to arise, that people might say, I've heard squats are great for this, I've heard that strengthening your core is great for disc problems, I've heard that I should avoid twisting and bending. All really good advice. The issue is how you do it specific to you, and that's where some of the problems tend to arise. So in a bit of a nutshell, disc, an acute disc, get it looked at, get it seen, make sure you rehab it properly, make sure you know what you can and can't do, make sure what you do works for you, because what I believe works might not be what physio number 2 believes, might not be what physio number 3 believes, but we all have different ways of managing people. If you've got chronic, long-standing disc problems, people will come to us and say, I had a disc problem, it was diagnosed 5 years ago, and my back's really, really bad now. I need a new MRI. And they go and get a new MRI and there's no change whatsoever. And the issue is that it's not so much the disc that's the issue, it's everything else around it has now adapted, because you've been quite rigid, because maybe you haven't moved. People are very afraid of moving their back, especially if they have a disc or a facet joint issue, and you need to learn how to move that, which is in a good way, so your movement is positive and your movement works for you. Because if you do something and you go, nah, every time I do that it hurts, you're not going to do it again. So we want you to a point where you feel, yep, I know what I'm doing here and I can do this, but when I get to this point here, that's my limit. And you stay here until you're ready to do the next spot. You don't suddenly go from been told to work my core, I'm going to start and I'm going to do boot camp next week. I haven't done anything for 5 years, because you will be sore. So, discs are a little bit predictable if you've had them before and you know what to expect, and generally people will know what they can and can't do. The issue is if you are not sure what you want to avoid, generally is flexion and bending. What you generally want to improve is something like walking, and you want to make sure that whatever symptoms you have, that they're not tracking further down your leg, because the further down the leg they are, probably the worse the case of the top end near the back. Probably the recent research as well, or not recent research, but the last few years also says that if you have you're more prone to back injury first thing in the morning, and you're more prone to injury towards sort of mid-afternoon, end of the day. The reason being, first thing in the morning, overnight, all the body and the joints and the discs themselves absorb a little more fluid, so it's a little bit more fluidy and mobile in the morning, so a little bit more prone to be a bit more fluid and active. So first thing, just be a bit more careful. Later on in the afternoon, we're all being a bit more loaded, we're sat down a lot, we're starting to fatigue, and then we don't have the muscle activity that might sort of help us that way. So that's the sort of reason between the two. The other thing that tends to happen as well is that, especially if we know that we have a back problem, we think about things. So if you have, a 5 kilo gas cylinder or a 10 kilo gas cylinder, or you need to move this spot from here to here, you'll stop and you'll think about it, and you'll go, yep, that's heavy, let's move it this way, let's make sure that we're supported, let's get someone else to do it, let's, position ourselves. But if we drop this on the floor, we just go, oh, and we pick it up, or we reach here, or typical thing behind the footwell of the car or behind the chair. And it's those sort of little things, because we're not thinking about it, or we sneeze and we're looking that way and sneeze. We're not thinking about it because we don't associate it with risk, and they tend to be the one thing that sort of catches out. I always remember we had one of our pain specialists when I was back in the UK, who'd been working in the pain clinic for years, and absolutely fabulous at his job, and that was his job. He was helping everyone who was in pain with back pain, chronic pain, all that type of thing. And he herniated 3 discs because he reached down to pick up a bar of soap in the shower. And it's those stupid things that cause you the problem. So you're likely to think about things a bit more if they're heavy. You're likely to think about things a bit more if they're weights. You're not likely to think about things when you just do it because it's easy. So message of the day: acute discs, make sure you get seen. Don't just try and manage them yourself. Make sure you know what you're doing and why. As your discs get settled and you're 6-12 weeks into a disc problem, you'll probably find you come into that chronic side, and you really need to have had some sort of work done to switch your core back on, because when you're in pain, you're static and you're stiff and you don't move, and everything is really rigid, and then you tend to stay that way and don't move, and then end up 2-3 years down the track with a rigid back that doesn't move. And it won't just start moving because you start an exercise program. You need to start moving it in a way that's good, that challenges the deep muscles and works the deep muscles, so you can layer on the muscles on top. So, a bit of a rant this afternoon on discs. Any questions, feel free, let me know, or you can flip me an email at info@thecoreexpert.com.